Dear colleagues, welcome to today's ESC webinar on the pericardial disease spectrum. How the guidelines help us manage this condition. I am Professor Yehuda Adler, the chair of the guidelines from the Sheba Medical Center, Israel, and my co-chair here today is Professor Massimo Masio from Torino. Massimo is the coordinator of the guidelines for pericardial disease, ESC 2015, who are the second European guidelines after the first was published in 2004. And with us, Professor George Kraspoulos from Oxford, who is the expert for pericardial surgeries. The aim of this webinar is to give you a better understanding of pericardial diseases, etiologies, symptoms, procedures, diagnosis, including MRI, CT, cardiac catheterization, and of course, treatment of the various diseases in the pericardial field based on the new guidelines on pericardial disease 2015. As a short introduction of what we are going to be discussing in the next hour, we have noted 10 of the leading commandments from the guidelines. Professor Massimo Masio will present 2 medical cases that cover a large part of the guidelines, and at the end, this 60-minute live event, you will have a better understanding of pericardial diseases. You will be able to continuously ask questions throughout the webinar. This session is highly interactive, and we strongly encourage you to actively participate by sending your question, your comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment session in the form of MCQs that will be submitted during the presentation. Anything you need to know, just ask, and we will provide tips and tricks for your daily clinical practice. I want to show you now the 10 commandments we prepare for you, who are like a summary for the ESC 2015 guidelines. Commandment number 1, hospital admission is recommended for high-risk patients with acute and recurrent pericarditis, defined by a risk factor, either predictor of a specific cause, non-viral or non-idiopathic, other of increased risk of complication. Number 2, colchicine is recommended as first-line therapy for acute and recurrent pericarditis as adjunct to aspirin and non-steroidal anti-inflammatory drugs therapy. We have to remember that corticosteroids are not recommended as first-line therapy, and Massimo will discuss this for sure. Commandment number 3, pericardiocentesis or surgical drainage is indicated for a cardiac tamponade or for symptomatic moderate to large pericardial effusions, not responsive to medical therapy, and the suspicion of bacterial or neoplastic etiology. Number 4, the mainstay of treatment of chronic permanent constriction is pericardiectomy. Number 5, a general diagnostic workup should be performed to identify causes that require targeted therapies. A modern approach for the management of pericardial disease should include the integration of biological markers as well as different imaging modalities. Commandment number 6, routine viral etiology is not recommended in acute pericarditis, with the possible exception of HIV and HCV. For the definitive diagnosis of viral pericarditis, a comprehensive workup of histological, cytological, immunohistological, and molecular investigation in pericardial fluid should be considered. In the absence of such argument, the term presumed viral pericarditis should be used. Number 7, in patients living in non-endemic area, empiric anti-TB treatment is not recommended when systematic investigation failed to yield a diagnosis of TB pericarditis. By contrast, in patients living in endemic areas, empiric anti-TB chemotherapy is recommended for exudative pericardial effusion after excluding other causes. Commandment number 8, effective pericardial drainage is recommended for purulent pericarditis as well as administration of IV antibiotics. And number 9, cytological analysis of pericardial fluid are recommended for the confirmation of malignant pericardial disease. Pericardial or epicardial biopsy should be considered for the confirmation of malignant pericardial disease. And last but not least, number 10, aspirin is not recommended for therapy of acute pericarditis in children, but non-steroidal anti-inflammatory drug at high doses are recommended as first line of therapy. Now, after those 10 comments to summarize very, very briefly the 2015 guidelines, I will hand over to Professor Massimo Emasio. Massimo.
Thank you very much. Welcome to everybody. My first case is a case of refractory recurrent pericarditis. It is a case of a 30-year-old woman with recurrent pericarditis on corticosteroids. And the first episode of acute pericarditis was reported 4 years ago with chest pain, mild pericardial effusion, and elevation of C-reactive protein. The etiological diagnostic workup was negative, and the final diagnosis was idiopathic acute pericarditis. The first treatment was ibuprofen, 600 milligrams twice daily. The first recurrence occurred within 6 months, and was treated by prednisone, 50 milligrams with good initial response and planned tapering within 4 weeks. Recurrences occurred at each attempt to reduce prednisone under 15 to 25 milligrams per day. And now she's referred to us for a second opinion to manage the therapy. And the current therapy is prednisone 25 milligrams per day plus colchicine 0.5 milligrams twice daily. My first question is, how would you confirm the diagnosis of recurrent pericarditis in this patient? First option, recurrent pain is sufficient to make the diagnosis in a patient with the previous pericarditis, especially if the patient is able to recognize the same chest pain. Second option, recurrent pericarditis is not sufficient and recurrent pericardial effusion is mandatory. Third option, recurrent pain is not sufficient and evidence of systemic inflammation is needed, for instance, elevation of C-reactive protein. And last, there are no specific criteria and clinical judgment is essential.
Thank you, Massimo. You have 1 minute to answer question number 1, but meanwhile, I want to ask you, Professor Emasio, we know that corticosteroids are not the first-line therapy, and we investigate it and prove it in several big trials. How do you explain doctors continue to treat patients with corticosteroids?
Yes, because it was a common treatment, especially in the past, because we know that corticosteroid can offer a fast response you can fast control of symptoms and also regression of pericardial effusion. But the main problem is that the experiences show with us that either retrospective or prospective, that they are associated, especially with the fast tapering, to more recurrences and also a higher risk of chronicization. So it should be considered only as a last option.
Okay, thank you, Massimo. I can see by the results here that 15% thought number 1 is correct, 70% number 2, 41% gave to number 3, and 26% to number 4. Let's make a little discussion about those results of the audience.
I'm not surprised that, in fact, it is very important to have evidence of inflammation in these patients, and recurrent pain is not enough to make the diagnosis. We need an objective evidence of disease activity. And if you look at the diagnostic criteria that are presented in the guidelines, so pericarditis chest pain is one of the diagnostic criteria. We have also to consider other criteria that are represented by pericardial rubs, new electrocardiographic changes such as widespread ST7 elevation, PR depression, and new or worsening pericardial effusion. But there are also additional supporting findings that should be considered, especially elevation of marker of inflammation such as C-reactive protein. And now also by imaging, we can have evidence of pericardial inflammation by computed tomography or cardiac magnetic resonance. And you can see among the main novelties of the guidelines, there is a new role for C-reactive protein, because C-reactive protein may be very helpful for the first diagnosis of acute and recurrent pericarditis. You can see in the slide that about 80% of patients will have a positive test at presentation. And you can see that if you perform this test after 1 week, 2 weeks, 3 weeks, and 4 weeks, you can see that the number of positive exams are declining, showing that the disease activities can be controlled by anti-inflammatory therapy. So C-reactive proteins can be very helpful for the diagnosis, but also for the monitoring of the inflammation, because in that way therapy can be individualized and therapy can be maintained until symptom resolution, especially normalization of C-reactive protein.
And I have to ask you, one of the audience asked me here, could inflammatory markers be used to determination of the length of treatment?
Yes, it's a very good and important question. What we propose in the guidelines is that the therapy duration should be individualized and tailored to the single patient. So not only till symptom, the attack dose of anti-inflammatory drugs should be maintained till symptom resolution and normalization of C-reactive protein, and then we suggest tapering of the drugs.
Okay, let's continue.
So very important question.
Okay.
The second important aspect of the guidelines, another important novelty, is the new role of imaging to detect pericardial inflammation. Mm-hmm. It can be demonstrated by computer tomography, but especially cardiac magnetic resonance. You can see a case here in these figures showing that if a patient has pericarditis, you can imagine pericardial inflammation that can show us on cardiac magnetic resonance. In the panel A, you can see pericardial thickening as demonstrated in T1 weighted imaging here. In the panel B, you can see also that the inflamed pericardial can show us in pericardial edema that on T2 weighted images as an increased signal. You can see the white signal here from the pericardium. And in panel C also, we can also detect pericardial late gadolinium enhancement, as you can see here, showing us increased extracellular space that in the acute phase is expression of a pericardial edema, but later can be also expression of pericardial fibrosis. So the imaging is very important nowadays for the evaluation of these patients. And so going to the presentation of this patient, the patient has evidence of side effects related to the prolonged corticosteroid therapy. The patient has evidence of stria rubra, and she also complains of pericarditis chest pain that is similar to the previous pericarditis chest pain that was reported in the acute attack, non-specific electrocardiographic changes, a mild pericardial effusion on echocardiography, elevation of white blood cell count and C-reactive protein. And here you can see an image with the stria rubra in the abdomen of this patient. We can have several systemic side effects that can be either psychiatric related to skin and soft tissue, neurological, cardiovascular with hypertension, even diabetes, and several that can be very severe in about 25% of this patient, especially if we use high doses of corticosteroids. So a very big problem for this patient. Here you can see the electrocardiogram of this patient showing non-specific ST-NT changes and also the evidence of a mild pericardial effusion on echocardiography. So my next question is, what is the next therapy to offer to this patient? First option, increase the dose of prednisone to 1 milligram per kilogram day. Second option, add a non-steroidal anti-inflammatory drug, and fast tapering of prednisone is warranted as soon as the symptoms are controlled. Third option, add a non-steroidal anti-inflammatory drug and try to manage the recurrence without increasing the dose of prednisone. Then slow tapering of prednisone is warranted. And last option, try a new therapy resorting to alternative immunosuppressive therapy.
Okay, and again, you have 1 minute to answer this question. And meanwhile, George, till now you have no work.
Yes, well, that's good. That's good. It's, I think it's very important to point out that we should try the best we can to treat these patients with medical management, because a large proportion of these patients will respond, and we should concentrate thereafter for those that do not respond and trying to treat them appropriately with whatever means we have. Surgery is always the last resort, and it should be kept like that. It is vital that these kind of complex cases, when they become more and more complex, they should be treated in a tertiary hospital with all disciplines available, and the treatment should be individualized to the patient that we treat.
Yes. Massimo, we have another question, and the question is, for how long I should treat the patient with colchicine after acute and recurrent pericarditis? A very good question.
Yes, very good question. Thank you, because very important. We had several trials showing that colchicine should be considered for 3 months in a patient with acute attack, with the first attack of pericarditis, and for 6 months in patient with recurrent pericarditis. But in more complex cases, we can consider also longer treatments up to 1 year, depending on the complexity and the severity of the case.
Okay, and I have the results. And the results are, result number 1, 4%, number 2, 18%, again, majority to number 3, 59%, 60%, and 20% to number 4.
Okay.
What can you discuss about the results?
I totally agree with the colleagues. One of the most important tricks in patients with corticosteroid dependent pericarditis is try to manage the recurrence without increasing the dose of prednisone. and try to control the symptoms by the use of aspirin or non-steroidal anti-inflammatory drugs plus colchicine, and then to consider tapering, a slow tapering of prednisone only once the recurrence is controlled. Because in our clinical practice we have different main causes. We can have autoimmune causes, connective tissue diseases, but the most important cause of recurrences in clinical practice is the inadequate treatment of the index attacks and the recurrences. If you use corticosteroids, high doses especially, fast tapering of drugs without considering C-reactive protein as a marker of disease activity and without individualizing the therapy, we can have more recurrences because we are not able to control the inflammation or the pericardial inflammation. And so this is very important. So we also put in the guidelines, either for acute or recurrent pericarditis, that corticosteroids are not recommended as first-line therapy for acute pericarditis, but this also applies to recurrent pericarditis. And you can see the commonly prescribed anti-inflammatory drugs for recurrent pericarditis that include aspirin or ibuprofen or indomethacin plus colchicine. And here you can see the duration of therapy, the proposed duration of therapy is 6 months for patients with recurrences.
But I want to emphasize what you said before. If you give colchicine, and it's a very complicated cases with a lot of recurrences, you should do it more than 6 months, even for 1 year.
Yes, I agree with you. And this is an important evidence showing that high doses of prednisone should no more considered in clinical practice. This is a comparison of 2 different regimens, high doses such as 1 milligram per kilogram day of prednisone versus low doses that are 0.2 to 0.5 milligram per kilogram day. You can see that patients treated with high doses have more recurrences during follow-up, so a worse event-free survival compared with low doses. And this is especially due to the frequency of severe side effects that are reported up in 25% of cases, often leading to drug withdrawal and also to hospitalization. So it is very important now to consider low doses, such as a common practice also in rheumatology when we have to treat serositis.
Or not at all, or not at all.
Yeah, or not at all, absolutely.
Very important point for the audience. We don't like and we don't need to treat corticosteroids for pericarditis unless there is no other chance. Because corticosteroids cause more recurrences. And after the patient are coming to me, and I'm sure to Massimo too, and with a lot of recurrences because of corticosteroids, it's very difficult to cure them. And they will go in the end to you, George.
Yes.
Yeah. Okay.
Okay. And the other important point is that if we resort to corticosteroids, we have to consider a slow tapering. And this means that using low doses, such as 25 milligram of prednisone, such as in this patient, the tapering should be of 2.5 milligram day every 2 to 4 weeks. So in this case, the tapering should be very slow, and every decrease in the prednisone dose as marked here should be done only if the patient is asymptomatic and C-reactive protein is normalized, especially for doses of less than 25 milligram per day. So the progression of the case is that corticosteroid is maintained following this general rule. So at 25 milligram per day, we maintained also colchicine, and we tried to control the symptoms by ibuprofen that was prescribed at the doses that are recommended in the guidelines of 600 milligram 3 times daily as attack dose, then for 10 days, then tapered, and a gastroprotection was prescribed with a proton pump inhibitor, a very important point. If you are prescribing high doses of non-steroidal anti-inflammatory drug, you have always to consider a gastroprotection. And the subsequent tapering was also suggested, reducing the dose of prednisone to 2.5 milligram every 2 weeks after remission of the recurrence attack. But unfortunately, in this case, ibuprofen was not tolerated because of gastrointestinal intolerance, and so the drug was withdrawn with worsening symptoms. We tried to control the symptoms with aspirin, but again, also aspirin failed because of gastrointestinal intolerance, and also indomethacin was not well tolerated by the patient because of severe EDH, dizziness, and epigastric pain. And so my next question is now what to do with this patient. So we have a problem with the non-steroidal anti-inflammatory drugs. So what are the options to offer to this patient? The first option is to increase the dose of prednisone now to 1 milligram per kilogram day. The second option is to consider azathioprine. The third option is to prescribe intravenous immunoglobulin. The next option is to prescribe anakinra, 100 milligram per day subcutaneously, or last option, consultation for pericardiectomy.
And again, you have 1 minute to answer. And George, meanwhile, I want to ask you, constrictive pericarditis.
Mm-hmm.
We published our data that recurrent pericarditis never do constrictive, only acute. But we know there is a high mortality rate in this operation. Can you tell something about it?
Indeed, if you look to the published data, there is a mortality that is ranging from 7 to 20%.
Right.
A lot of the published data refer to operations performed decades ago. I think following the guidelines, following the existing knowledge, interrogating and identifying the patients that they should progress to surgery, and prepare them enough, and if possible, pick them up early enough to not allow them to fall into New York Heart Association 4 stage and with a lot of fibrosis and muscular atrophy. We should be able to keep mortality and morbidity at a lower level. It is important for these complex cases to be treated in tertiary environment with a multidisciplinary team and specialist care from the cardiology, surgery, imaging is of paramount importance.
Thank you, George. Massimo, we have the answers. Now we have 5 choices. Number 1, 70%. Number 2 is leading with nearly 50%. And 10% to number 3, number 4, 8%, and 80% to number 5. Let's talk about consider azothioprine.
Yes, yes. So probably we don't have the right, probably we know that it is not correct to increase the dose of prednisone, so the option 1 is probably the wrong one here, but probably for the other option we have to consider patient by patient, considering also the specific situation, the local expertise, that we have to offer something more. And in the guideline also
But I have to ask you, why do you think most of the audience thought number 2 is the most correct, 50%?
Yeah, because it is an old drug, it is rather cheap, it is a possible
But
option.
what about researchers to prove it?
Well, yes, we have to say that this is supported especially by case reports and case series. But
and I want to ask the audience to go to American Journal of Cardiology. Last month we published a review article about this, and you will see the exact data that Massimo told very correctly about this, about the proofs about all the drugs after, like azothioprine, immunoglobulin, and others. Yes, Massimo.
So in the guidelines, we propose a therapeutic algorithm showing that if you have a recurrence, the first line is aspirin, non-steroidal anti-inflammatory drug plus colchicine, exercise restriction. We tried with this. The second line include low-dose corticosteroids, and they can be combined in more difficult cases with also first-line therapies. But if, as in the case of this patient, have problem and the patient still have recurrences, we have to consider third-line therapy. And third-line therapies are especially based on case reports, and they can, azothioprine is probably the cheaper option, but we have also to consider other emerging options that include intravenous immunoglobulin and anakinra. And the last option is the patient also do not respond to this therapy, is to consider also pericardiectomy. And here you can see the mechanism of action of this new emerging therapy. First of all, we have to consider that all these treatments are off-label, and that the level of evidence to support this treatment is different. So if we consider, first of all, anakinra is essentially a competitor of interleukin-1. So anakinra is an interleukin-1 antagonist. So in that way, this drug is able to block activated monocyte and macrophages. For this drug, we have that should be administered subcutaneously. We have only case reports, and there are ongoing clinical trials. It has been demonstrated as especially useful in corticosteroid dependence patients, especially in the pediatric setting, but we have also data in adults. Colchicine is probably the drug that collects more evidence. Evidence is based on multi-center randomized clinical trials. And so in the guidelines, colchicine received a class 1 recommendation with the level of evidence A. Colchicine is able to concentrate in granulocyte and is able to block tubulin polymerization, and in that way interferes with granulocyte function. Azothioprine is an old drug, is a cheap drug. It blocks purine and DNA synthesis and inhibits lymphocyte proliferation. It is a well-known drug in different conditions. Intravenous immunoglobulin, also another emerging option that is supported especially by case report and series. It is able to modulate the immune system, but also to increase the clearance of infectious agents. So it can be helpful both in immunomediated recurrences, but also in infectious pericarditis. Here in the guidelines, this is the table from the guidelines reporting the dosing and also the specific indication for these drugs. And the last option that nowadays should be considered, especially based on the experience from the Mayo Clinic, is the pericardiectomy. For refractory recurrent pericarditis, it is refractory to all medical therapies. This retrospective review of cases show us that surgically treated patients may have a better event-free survival compared with medically treated patients. So this is an option that should be considered also for these patients that are more difficult.
And here, George, I have to ask you, we have data about constrictive and pericardiectomy. We don't have a lot of data about pericardiectomy for recurrent pericarditis. Mm-hmm. And Massimo and I are doing our best that the patient won't come to you by mm-hmm. treatment, with no conservative treatment. What do you have to tell us, the audience, about pericardiectomy for refractory recurrent pericarditis? Mm-hmm.
Pericardiectomy it's a highly effective and frequently is a curative procedure for this kind of patients, for the right patients. It should be done appropriately, and it should be done on the patients that they are more keen to survive the operation. There have been some publications where they looked into why the patient died or behaved badly following a surgical pericardiectomy. And post-mortem has shown that those patients that they actually died were the ones that they had either muscular atrophy or high level of fibrosis. Yeah. So you remove the pericardium, but there is no heart underneath to recover. So if we actually are selective, increase our selection criteria, pick up the right patient, do it in a progressive manner and in a multidisciplinary approach, I think that we should be in a position to offer an effective and potentially curative surgical procedure to the appropriate patients with relatively low mortality and morbidity.
You have lower mortality in those kinds of patients compared to constrictive pericarditis patients, I imagine, because in constrictive pericarditis, the involvement of the myocard is much more than in recurrent pericarditis.
Exactly. I suspect that is true. It's also the etiology underneath. Is it tuberculosis? Is it what is the etiology? Actually matters a lot. Let's say in tuberculous pericarditis, you may get a lot of calcifications that they grow inside the muscle. You'll never be able to remove them. So there are a lot of. We need to individualize the actual therapy to the patient, yeah, which is extremely important. So the difficult cases, they need to go into to a tertiary hospital when everything is available.
Thank you.
Thank you. Yes, I guess so. Just the key messages from this case is that refractory recurrent pericarditis is a troublesome condition, usually immune-mediated, but without a well-established classical rheumatological diagnosis. Inadequate treatment is the main cause of incessant and recurrent curves in clinical practice, and so we should use aspirin and non-steroidal inflammatory drugs plus colchicine as first options for this patient. Avoid corticosteroids as much as possible, and if we really need to use these drugs, consider low to moderate doses if needed with a slow tapering. That is really critical. We have also to consider triple therapy, including aspirin, non-steroidal anti-inflammatory drug plus colchicine plus low to moderate dose of corticosteroids in this patient. And if we have a true resistance to conventional therapy, we have to consider a new therapeutic option that probably should be considered, especially in a tertiary referral center, because we know that all these therapies are off-label, with the possible exception of azathioprine, and pericardiectomy should be considered the last option for these patients.
Thank you very much. We have several questions, but one of the questions is very, very important, and we had a conversation about it in the task force for the pericardial guidance. Can we use colchicine during pregnancy?
Okay, this is a very important question. So, the use of colchicine for pericardial diseases is due to Baez de Luna that used colchicine for the first time several years ago, following the good experience they had with the familiar Mediterranean fever, an autoinflammatory disease where colchicine is used to treat and prevent recurrences of serositis. in different settings, including pregnancy and even in children. And the drug is very safe in this setting. However, we have the drug has the potentiality to be teratogenic. So unless there is a specific indication, such as familial Mediterranean fever, colchicine is now considered contraindicated for this patient. So we need additional data, probably.
Although we don't have data.
Yes, we don't have data.
We don't have data. It's something historical without data. So we have to be careful, but we don't know exactly of what. We have to admit.
Yes, absolutely.
George, you want to add something?
No, I think Massimo has summarized quite nicely everything.